Thank you.
A very good morning. Can I have the slides, please?
Can we have Dr. Shruti's presentation, please? Thank you.
Good morning. I would like to thank Dr. Rohit and Microvision for this wonderful opportunity. Today I'll try to answer the million-dollar question, which is stronger in refractive surgery. I'm sure all of us have these questions in our heads. When should I offer SMILE to the patient? How do I counsel for SMILE procedure? And is there enough evidence biomechanically that SMILE is stronger than LASIK? So the research question we proposed was, what causes greater biomechanical weakening? Who's the culprit? Who's the real culprit? Is it the flap or the cap, or it's just the laser? So we did a novel work where biomechanics was attempted with mathematical modeling in steps. That is, flap cut in LASIK and cap cut in SMILE, and then again after ablation and lenticule removal. To improve the analysis, we used Corvis ST, and we built an analytical biomechanical model, which we have already published in this previous studies. So I'll quickly describe our model. Here, T1 is the time before applanation, T2 is when the cornea is totally applanated, T3 is when the cornea has regained its shape but not returned to its original position. So using this difference of T1 and T2, we can calculate the deformation amplitude, which is shown in the red squares in the figure. But not to forget, the periphery of the cornea not getting applanated directly by the air puff also moves back and forth, which is shown in these blue circles. So the difference between deformation amplitude and the whole eye movement, we can use this to calculate the deflection amplitude, what we call, which is purely of the cornea. This analytical equation lets us calculate the force applied individually on the cornea and the extracorneal tissues respectively. This graph of force versus deflection curve is equivalent to stress versus strain graph. So using Corvis ST, we can derive the corneal stiffness. We conducted a longitudinal prospective interventional study of 30 patients with prior ethics committee approval. Here we matched them for refraction, pachymetry, biomechanics, and intraocular pressure. It was a contralateral study where one eye underwent LASIK and the other eye underwent SMILE. So very interesting experiment where we took the Corvis pre-op measurements, then shifted them to OT. Then flap cut was performed for LASIK eye and cap cut was performed for the SMILE eye without disturbing the tissue. We waited for 4 hours and then we retook the measurement of the Corvis for the biomechanics. We shifted the patient back to the OT and then the rest of the surgery was completed, which is the ablation and the lenticule removal. So here are the interesting results. Talking about the deflection amplitude, there was a statistically significant change noted before and after flap cut in LASIK, which was not observed in SMILE. So I'll also show some representative case examples. This was a patient who underwent SMILE. This is a waveform analysis in which one of the eye which underwent SMILE, we look at the corneal force versus deformation plot. So a very minimal change of corneal stiffness was observed after flap cut. In contrast to this, the LASIK eye, we can see that there was a drastic drop in the corneal stiffness just by cutting the flap. We also look into the Corvis biomechanical index. Here there was no statistical difference between SMILE patients before and after cap cut, whereas you can see it here that 18-fold rise in the Corvis biomechanical index was observed after flap cut in LASIK eyes. So what is very unique about this study is no previous study has shown biomechanical weakening caused by flap or cap cut exclusively before the ablation or lenticule removal. And a significant difference in biomechanics was observed after flap cut in LASIK, but not after cap cut in SMILE. But wound healing of corneal tissue and reduction of the biomechanical stresses after healing was equivalent. So what is the future prospect of this study? By combining cellular biomarkers with predictive mathematical modeling, we can use this data for customization of refractive surgery patients. Thank you so much.